All right, hello there, everybody. Yeah, let's just do the Kahoot review for the test. Basically, I'm going to go ahead and just narrate this. I've posted the link for the Kahoot as well on Canvas, and I suggest you go along yourself, kind of go through it, and yeah, try to answer the questions, see what you think, and then I'll kind of talk through the answers a little bit, kind of like what we do in class. And I turned off the randomized order of the questions, so that way you can kind of do them in the same order I am, so it's not kind of jumping from topic to topic. So this will be pretty much kind of in order, not necessarily the order we went in class, but in order via topic. But anyway, let's go ahead and get started here. All right, so the first question is, what would be a strategy to try to prevent acute kidney injury for a patient on amikacin, say for gram-negative coverage of pneumonia? What would be a good way to try to prevent that acute kidney injury? You can either add Lasix to their medication regimen, you can try to place the patient on maintenance fluids, use Q6-hour dosing, or try to make sure the trough is above 2 micrograms per ml. So the right answer is actually to place the patient on maintenance fluids. Really ensuring good hydration is one of the best things you can do for these patients, which is why something like adding Lasix to their medication regimen wouldn't really be all that useful. You're going to find that, yeah, even though you can keep urine output up by using something like Lasix, if anything, you can dehydrate the patient worse and kind of cause more of a pre-renal sort of kidney injury from that case there, because they'd be underperfusing the patient's kidneys. So Lasix would not be correct there. Using Q6-hour dosing is also incorrect, mainly due to the fact that we want to try to get down to undetectable levels for something like an aminoglycoside, right? And so by using Q6-hour dosing, you're more likely to see accumulation of drug in the kidneys and say accumulation in the renal tubules, and that's where all that damage actually occurs there. So, and again, we don't keep the trough above something, we want to get below that 2 micrograms per ml. And that way we're not accumulating drug, you're clearing it through the kidneys just fine, and then you don't have the acute kidney injury, hopefully. Right? So that's why we want to keep the right answer as putting them on maintenance fluids. And I'm apparently not going to do very well this game because I'm not answering the questions myself. Oh well. Up next, acute kidney injury from cisplatin would be categorized as post-renal, intrinsic, or pre-renal. So what do we think about that? Well, I would think this is actually going to be a case of intrinsic damage being done by cisplatin. If you remember, the way the cisplatin works is it's an alkylating agent, it likes to alkylate DNA and causes cellular damage to the DNA, which triggers off apoptosis, right? So because you're actually having damage done directly to the renal cells, that's why it's considered being more of an intrinsic sort of kidney injury. The damage is done to the kidney itself. It's not before the kidney, it's not after the kidney, right? Example of a post-renal kidney injury would be something like methotrexate precipitating out, say, past the collecting ducts. If you had rhabdomyolysis causing blockage secondary to, say, statin use in a 3 or 4 inhibitor, acyclovir in the crystal urea. All those things are more of a post-renal issue. BPH impinging on the urethra could be considered a post-renal issue as well, right? Pre-renal typically is going to be due to underperfusion of the kidneys, mainly dehydration, but also a lot of vasoconstrictors like epinephrine, norepinephrine, things like that will also cause more of a pre-renal issue where you're not sending enough blood and oxygen to the kidneys. So cisplatin would be intrinsic. Amphotericin B would be intrinsic. The aminoglycosides are intrinsic. Anything doing direct damage to the renal cells themselves are going to be intrinsic. Up next, acute kidney injury caused by lisinopril will be categorized as, and so again, going back to what we already talked about, you think it be intrinsic, post-renal, or pre-renal, keeping in mind what the mechanism for lisinopril is. And so we actually find that this is going to be a pre-renal issue. And so the reason for that is because lisinopril is going to decrease production of angiotensin II. Angiotensin II normally is going to cause constriction of the efferent arteriole leading out of the glomerulus. And so by doing that, you relieve that pressure, and that filtration pressure is actually going to go down. So you're going to be sending as much product through the glomerulus as you would be otherwise. And so we consider that a pre-renal issue because it's not really to do with the renal cells themselves. It's more of a flow issue, a pressure issue than it is anything else. So we consider that pre-renal, NSAIDs would be considered a pre-renal issue as well, versus intrinsic or post-renal. Which of the following could worsen hyperphosphatemia in a patient with renal osteodystrophy? All right, so looking at this, okay, hyperphosphatemia, looking at aluminum hydroxide, cinacalcet, calcitriol, or calcium acetate. Which one of these could worsen the hyperphosphatemia seen in a patient with renal osteodystrophy? So it would actually be calcitriol. Calcitriol, however you want to say it. The reason for that is thinking back to the mechanism how these drugs are working. For one, if you remember, aluminum hydroxide is actually a phosphate binder, so that would cause levels to go down, preferentially. Calcium acetate is also going to be a phosphate binder, so that should cause levels to go down, should mitigate hyperphosphatemia. And then the question is between cinacalcet and calcitriol. And so this is important to keep the distinction between the two clear in your mind as far as what mechanisms are going to have here. And so calcitriol, if you remember, is going to be the activated form of vitamin D. And the effects of vitamin D on the parathyroid includes reabsorption of calcium from the renal tubules, but also phosphate. So in those cases there, you can actually find that, chronic kidney disease patients need activated vitamin D, but this calcitriol can actually worsen some of the underlying issues, namely the hyperphosphatemia, which we know too much phosphate is going to bind up calcium. It's going to lead to more bone resorption. It's going to lead to more fragile bones, potentially fractures, etc. Cinacalcet, on the other hand, though, is actually going to be able to basically get those levels of parathyroid hormone down by making, it's kind of like a mimic, kind of making the parathyroid think you have enough vitamin D without actually activating. And so by doing that, you're going to be able to mitigate the effects of calcitriol there and not have as much of that bone resorption, not have so much of that the phosphate being reabsorbed from the kidneys. You can flush that out in the urine. And so in that case, they're saying calcium would actually help with hyperphosphatemia, whereas calcitriol could potentially make it a little bit worse. Next, a patient with a sodium of 110 milliequivalents per liter is seizing. Which of the following fluids is most appropriate to use? We have 0.45% sodium chloride, we have 3% sodium chloride, 0.9% sodium chloride, or D5W. As the patient has sodium 110, they're actively seizing, what fluid is going to be most appropriate? Answer is 3%. It should probably be pretty straightforward. Whenever you have a patient who's actively seizing and you suspect that it's the sodium, and in this case it seems pretty clear cut, you need to get that sodium corrected quickly, right? Now, again, the rule of thumb is you don't want to do more than 12 milliequivalents within the first 24 hours, so perhaps you give them a dose of 3% initially to get the seizing under control, right? So you stop the seizures, and then you kind of recheck the sodium to see where they're at. So maybe you got 4, 5, 6 milliequivalents taken care of right there with that bolus of 3%, and then for the rest of that 24 hours, you would just subtract that from your 12, and that would be what you're going to replace for the rest of the day there, right? But the main thing here is that the patient's having very severe symptoms, sodium's low, you got to correct that, and the best way to do that is with the concentrated sodium chloride. You could use something like 0.9% of normal saline, but it's just going to take too long, right? And so the patient's seizing, time is tissue. You want to save that brain tissue as best you can, so 3% would be appropriate here. You find that half normal saline, again, is not going to do it. Not enough. You have to get so much volume there to even get the patient up. And if anything, you think with half normal saline, it's 77 milliequivalents per liter of sodium anyway. So it's really going to, if anything, kind of drive that sodium down a little bit more. Whereas the 0.9% is 154 per liter. That can definitely drive it up. So and then D5 is just free water, so that would also just make our problems worse when you have a sodium of 110 already. So 3% would be appropriate. Now, when you're saying having a patient with, say, less severe symptoms, then you can make that decision between, say, 0.9 and 3% based off things like volume status being a big one. If the patient is hypovolemic, normal saline might be okay, right? Because it's going to help to replenish volume and salt, versus if they maybe are edematous or euvolemic, 3% is going to be more appropriate, because that way you get the sodium in without as much volume. Okay, moving on to surgery. Which sedative agent could be used for induction prior to surgery? So we use desflurane, propofol, cisatracurium, or sevoflurane. Now, we haven't talked about paralytics too much yet, so don't worry about the cisatracurium. Let's just say that one's going to be an incorrect answer. We'll talk about that in the emergency medicine section next couple class sessions here. But again, going through desflurane, sevoflurane, and propofol, which one would be a good as an induction agent prior to surgery? Well, the right answer here is going to be propofol. The question is, why is that one good for induction whereas the other two are not? Well, the reason for that is, if you go back and look at our slides, you see that for induction of sleep prior to surgery, you want something that's very fast acting. Something's going to knock the patient down quickly, so that way you get the patient down, get them ready for surgery, do your thing. Propofol is good for that. It's a good IV agent, very good at getting them down for general anesthesia, or just use it as a good sedative for maybe conscious sedation, right? So say you're doing something in the ER, sewing up a laceration or reducing a shoulder or something like that. So that's good for induction. Desflurane and sevoflurane, really all of your inhaled anesthetics are going to be better for maintenance of sedation rather than induction, mainly because they just take too long to kick in, right? So you want to use something that's fast acting, get them down, and then you can maintain them with one of the inhaled products. Okay. The other benefit with the inhaled products is that once you stop them, they wear off pretty quickly, and so again, that helps with the recovery process as well. Cisatracurium is going to be a paralytic we'll talk about, and basically that is going to be able to help with maybe getting the patient intubated, helps to kind of loosen up all those muscles in the neck, and then also for helping them to be synchronous with the vent. There's different reasons why we paralyze a patient, but we'll talk about that later. Up next, which opioid may cause chest wall rigidity when given too quickly? The morphine, fentanyl, heroin, or hydromorphone? So chest wall rigidity. That's actually going to be fentanyl. Fentanyl is a very popular opioid to use in the surgical setting, mainly due to its short duration of action and pretty potent effects. But yeah, this one, if you push it too quickly, it will actually cause chest wall rigidity to where the patient is not going to be able to ventilate very well, and in some cases you may either have to intubate, or in some cases you have to give Narcan to try to reverse those effects there. So that is a unique thing you want to think about with fentanyl that you don't see with morphine, don't see with hydromorphone, and typically we don't like to give our patients heroin in the hospital. And again, you just don't see that same effects with that drug. All right, up next, a patient with an allergy to lidocaine could safely receive prilocaine, procaine, mepivacaine, or bupivacaine. Which one could they receive? So again, this goes back to the chemical classification for the anesthetics. And so the correct answer would be procaine. Now again, if you have someone who has an amide allergy or an allergy to an amide anesthetic, keep in mind that you can always use your ester-based anesthetics because they don't have any cross-reactivity when it comes to the allergy there, right? So how do you determine the difference between an amide and an ester? If you remember, the naming convention helps with this, right? The spelling. If there's an I in the name prior to the cane, it's going to be an amide, and if there is not, then it's going to be an ester. So in this case, bupivacaine, mepivacaine, prilocaine all have an I before the cane, so you know they're an amide. Procaine does not, so you know it's an ester. That one would be safely can be safely administered to a patient with a true lidocaine allergy. Which of the following areas can you safely inject lidocaine? The toes, the fingers, the penis, the nose. Which one of these is appropriate to inject lidocaine into? And the correct answer is all of them. You can inject lidocaine anywhere you want, right? The big thing though is if it contains epinephrine. So that is where you have the restrictions there, because again, epinephrine is a vasoconstrictor. You're going to find that's going to decrease blood flow to those areas, the terminal blood flow to, say, the toes or the fingers. And so because of that, it can cause tissue ischemia, cell damage. We don't want to do that. So if it's just plain lidocaine, though, you can inject that anywhere you want. Patient taking zolpidem for sleep is at risk of all of the following except daytime drowsiness, seizures, tolerance, or physical dependence. Now keep in mind, I will not be asking, which of the following are true except type questions on the test, but again, we can be a little bit more freeform here with Kahoot. But again, which one of these is not expected with a patient taking zolpidem for sleep? So the answer is seizure. And it actually makes sense if you go back to the mechanism of the drug working on the GABA receptors, right? They work just like the benzodiazepines do. Again, you can use the benzos for sleep as well. And so you would not expect to see seizures. However, imagine you have someone who's taking this chronically and they were to come off of it cold turkey, you could expect potentially to see withdrawal symptoms and potentially seizures could be a part of that. If the patient happened to be predisposed to seizures. Now, things you would expect to see are certainly daytime drowsiness, especially with more long-acting or controlled release preparations of these products. Tolerance certainly develops here. We may need to up your dose in order to get the same sleep-inducing sort of effects. And the physical dependence is certainly going to happen. And again, all of your, we call them the Z drugs, like zolpidem, azopiclone, all of those are going to be controlled substances, just like the benzodiazepines are. They're C4s. So because of that, physical dependence, abuse is a potential, and so you need to be aware of that. So again, short courses are typically what's recommended for most of these short courses possible. Up next, which of the following insulins would be best to correct postprandial hyperglycemia? Would it be insulin degludec, would it be insulin lispro, insulin glargine, or NPH insulin? Which one of these would be appropriate? All right, so let's see. Actually, it's going to be insulin lispro. So let's look at the types of insulin we have here. So if you look at insulin degludec and insulin glargine, if you go back to your tables in your slides, you'll see that these are the ultra long-acting insulin preparations. They last 24 up to 36 hours in insulin degludec. And so that would not be good for postprandial hyperglycemia because it really wouldn't lead to a very quick correction, and you don't really, the effects are just too long, right? It's not good for those kind of quick after meal sort of bouts of hyperglycemia. Similarly, insulin NPH is going to be the intermediate acting, where it's more of a Q12-hour sort of dosing, and so it would not be appropriate for postprandial hyperglycemia. However, insulin lispro is a ultra short acting. You could see this with insulin glulicine, insulin aspart. Any of those would be appropriate for postprandial hyperglycemia. Even regular insulin would be appropriate here as well. But you want short to ultra short acting insulins for postprandial hyperglycemia. Which of the following would be most likely to cause weight gain? Glipizide, liraglutide, metformin, or glucagon? Which one of these would cause weight gain? Well, be the one that would directly stimulate insulin secretion, right? So that's your sulfonylureas. It could be your glutamides like Prandin, Starlix. Any of those that are directly stimulating insulin release are going to cause weight gain for the large majority of patients. However, what are some things that are going to be more weight neutral? Well, that includes things like metformin, which can help to be either neutral or maybe lose a little bit of weight. And then you have your GLP-1 agonists like liraglutide, which actually are probably going to cause a patient to lose weight, mainly due to the slowing down of gastrointestinal transit time, mainly due to the effects on satiety. They're going to be consuming less calories, right? So fewer calories in means they're going to probably end up losing some weight with that. Glucagon, again, that's only going to be like an as-needed thing for hypoglycemia. Should not really cause much changes in weight because your patient really shouldn't be using it that frequently. Let's say we have a diabetic patient who suddenly passes out and AccuCheck shows a blood glucose of 35 milligrams per deciliter. How do you proceed? Do you give 15 grams of simple carbohydrates like 8 ounces of milk? Do you give 4 units of regular insulin subcutaneously? Do you give 1 gram metformin PO, or do you give 1 milligram of glucagon IM? Which one of these are going to be able to correct the blood glucose of 35? Which, if you're not sure, is low. So the right answer is to give glucagon. Big thing here is that the patient has now passed out. They are not going to be able to take anything orally. You don't want them to choke on it, aspirate, etc. So because of that, you want to get something that's going to either be intravenous or intramuscular, right? So parenteral therapy is appropriate here. So pure carbohydrates are no good. If the patient maybe had a blood sugar of, say, 63 and they're feeling a little woozy, but they're still with it, certainly oral carbohydrates could be appropriate at that point, right? Insulin is just going to make the patient's hypoglycemia worse. Metformin is not really going to do anything for them. However, the glucagon is going to be the ticket here. And the main thing that's going to do is to help to stimulate breakdown of glycogen, turn that into glucose, and that's going to help to replenish that blood glucose and hopefully get more going to the brain, and the patient should regain consciousness. Another right answer here would also be things like intravenous dextrose. Usually D10, D25, D50, any of those would be appropriate here as well. Which of the following is the best initial treatment for a type 2 diabetic patient? Would it be regular insulin, rosiglitazone, acarbose, or metformin? Which of these would be appropriate? The answer here is metformin. Most of your type 2 diabetic patients should start on metformin unless they have a good reason not to. Say, for instance, they have poor kidney function, right? Say GFR less than 30. That would be a good contraindication to metformin. But these other things could also be potentially effective, right? So again, things like acarbose are going to prevent absorption of carbohydrates that can help get the blood sugar under control. Rosiglitazone is going to be able to affect that PPAR alpha transcription factor, and help out with insulin sensitivity, and certainly regular insulin will get the blood sugar under control. However, they're not good initial treatments, right? Acarbose has a lot of GI side effects. The rosiglitazone isn't really good as initial therapy, mainly due to cost and some of the potential risks, especially associated with patients like CHF. And then regular insulin, you typically don't want to start patients out on injectables because it's a lot more issues with administration, and people don't want to inject themselves, etc. So metformin kind of strikes the balance between being relatively safe, having good effects on weight, having a very low cost. Again, besides the GI effects, it is pretty hard on the stomach. It's a very good drug otherwise, and so most patients are going to end up starting on metformin because again, it's going to be good as an insulin sensitizer, helps us to use our insulin, make better use of it essentially. All right. So a diabetic patient develops a fungal UTI. Which medication likely caused this? Would it be sitagliptin, insulin detamir, duraglutide, or canagliflozin? And if you remember, the class of drugs that helps to cause basically a hyperglycemia in the urine, which the fungus is going to want to chow down on and start to proliferate, it's going to be the SGLT transporter inhibitors, right? It's a sodium glucose transporter. Prevents reabsorption of glucose within the urine, so it's going to cause you to pee all that out, but like I mentioned, the fungus likes to eat that and then start to proliferate. Sitagliptin, duraglutide, insulin detamir, none of those are going to cause the same risk for fungal UTI as canagliflozin. And really any of the SGLT2 inhibitors are going to also be a risk for causing this as well. Which of the following conditions would be improved by starting a patient on transdermal testosterone? It would be congestive heart failure, benign prostatic hyperplasia, gynecomastia, or osteoporosis. Which one of these would be improved by starting a patient on transdermal testosterone? Well, osteoporosis would be improved, actually. Testosterone has pretty positive effects on the bone, helping to make them stronger. Again, osteoporosis is not just an issue for females, it's an issue for men as well as they get older, and so it could be related to maybe losing some of that testosterone. So this can be fixed, can be helped by using transdermal testosterone. Note we don't like oral testosterone because it's pretty hard on the liver, right? It has a lot of hepatic effects, hepatitis, and that's not good. Now let's look at some of the other things. What could, obviously if testosterone is not going to help with these, it's probably going to make them worse, right? So things like gynecomastia, it's going to be worse, right? Because if you think about the way that the different sex hormones are produced, some of the testosterone gets converted over into estrogen, right? Specifically by the aromatase enzyme. So that can cause the gynecomastia you see there, right? BPH is actually going to get worse off of this. We'll cover this in urology, but basically testosterone is going to stimulate the actual tissue to undergo hyperplasia in the prostate, and it's going to cause it to be bigger and make your that impingement on the urethra even worse. So BPH is not going to be affected there. CHF could also be worse as well because testosterone tends to cause some degree of fluid retention, and so that can make edema worse, and not good for CHF patient, right? So in this case, osteoporosis would be the only thing that transdermal testosterone would actually improve. Which of the following can be used to treat both hyper and hypothyroidism? Be methimazole, propylthiouracil, levothyroxine, or iodide. Which one of these could treat either? Well, iodide is going to be the answer here. And you know, it makes sense, right? We need iodide in order to produce T3 and T4, but if you overstimulate the thyroid by giving too much, that is why you'll end up shutting things down, essentially, right? The production down. So you can either use iodide as a supplement to help encourage production of T3 or T4, or in case of, like, say, something like thyrotoxicosis, thyroid storm, you can actually give saturated potassium iodide. That's SKI, the saturated solution of potassium iodide, and that can actually help to limit further production of T3 and T4, which can be useful for those cases. Now, looking at the other answer choices, methimazole and propylthiouracil are both used to treat hyperthyroidism, actually prevent further formation of T3 and T4, and then levothyroxine is just T4, and so that's actually going to help to treat the hypothyroidism. Which of the following would have the fastest onset to treat hypothyroidism? It'd be levothyroxine, liothyronine, Liatrix, or saturated solution of potassium iodide. Well, the correct answer is liothyronine. If you think about it, why is this one going to be the fastest acting? Well, if you remember, T3 and T4 are both produced by the thyroid. However, which one's more active? T3 is. So T4 has to be converted over to T3, which is kind of explains why levothyroxine has a fairly long time before it'll actually kick in, right? It's just a very slow onset. Liatrix is actually a combination of T4 and T3. It's trying to mimic more of what your body would naturally produce. And so that would be a little faster because there's a little bit some T3 in there. However, liothyronine is actually just pure T3. So that would have the fastest onset, but clinically, you don't really need that increased onset of action, and so because of that, we don't typically do it. It's more expensive too, and so that's why I like to stick with just the levothyroxine. I already mentioned that the SSKI actually is going to could worsen hypothyroidism. If you already have enough iodide around, this could actually shut down further production. However, if you use the right dose and you're hypothyroid, due to lack of iodine, this could act as a supplement potentially and try to stimulate that. But very slow onset of action as compared to the liothyronine. Which of the following is true of renal function in neonates? So now moving into the PEDS question. So prematurity increases function and quantity of the nephrons. Serum creatinine is falsely elevated for the first several days. Urine output is the least accurate way of measuring function. Cockcroft gall is the preferred formula to calculate function. Well, it's that serum creatinine is falsely elevated for the first several days. And if you remember what we were talking about there is that you're actually measuring the mom serum creatinine. And so we don't really use formulas in neonates to determine what the renal function is. The best way to do that is going to be with the urine output, either through direct catheterization of the bladder, or if we have wet diapers, we can measure those, we can weigh them and determine how much volume the patient is outputting. That's going to be the best indicator right there, right? Other than that, once you have a child get a little bit older, Cockcroft gall isn't really appropriate because it's going to be more for adult patients. We have what we call the modified Schwartz equation, and that is going to be the preferred way to estimate renal function in a child. And then with the premature individuals, you're going to find that their function and quantity of nephrons is actually diminished as compared to someone who was able to gestate for longer. In PEDS, which of the following means of drug dosing is least sensitive to the extremes in weight? It would be height-based dosing, age-based dosing, weight-based dosing, or body surface area. Which one of these would be the least sensitive to extremes in weight? That, of course, would be the body surface area dosing. We do this a lot for chemotherapy for patients receiving chemotherapy for oncologic reasons. And so the reason why it is most accurate and least sensitive to extremes in weight is mainly due to the fact that it factors in the patient's height as well. So if you look up BSA formulas, and again, I don't know the formula off the top of my head because I just use a calculator, but if you look at what goes into it, it's height and weight. And so that way, if you have a patient who weighs a lot, but they're very short, that's going to be mitigated as compared to if you're just using the weight by itself, right? Because we know we're going to have kids that are overweight, kids that are underweight, and so it tends to be more sensitive to that. But by using the body surface area, by incorporating their height, that limits that effect of the weight there. So that's why we like that. Height-based dosing is not a thing. Age-based dosing is, you'll see that, but again, that does not take into account at all the patient's weight in terms of if they're over or underweight. And so that's probably one of the, it's easier for memorization purposes, but you're going to see it's not used as commonly. What is the maintenance fluid rate of normal saline for a 23 kilogram patient? Is it 63 mLs an hour? Is it 460 mLs an hour? Is it 23 mLs an hour or 43 mLs an hour? What is the maintenance fluid rate in S for a 23 kilo patient? So this goes back to using the 4-2-1 rule. And so, you remember, it means we have 10 kilos, or 10, we have 4 mLs per kilo per hour for the first 10 kilos, 2 mLs per kilo per hour for the second 10 kilos, and then 1 ml per kilo per hour for every subsequent ml, or kilogram. And so in this case here, because they are 23 kilograms, that is 40 mLs an hour, plus 20 mLs an hour, plus 3 mLs an hour, which equals 63. Again, you can double check my math there, but that would be the maintenance rate for that child. Now the question of what would be an appropriate fluid bolus, well that is when you would multiply 23 kilos by 20 mLs per kilo. So 23 times 20 is 460. So the blue answer there is actually going to be what their fluid bolus would be. So a little shy of 500. And then 23 and 43 are all just wrong. We have a patient who's 23 kilograms. We're using the drug amoxicillin. That's a concentration of 80 milligrams per ml. And then the dosing is going to be 90 milligrams per kilo per day, twice a day. What is the volume of a dose? Now, this is more difficult math than what you're going to need to do on the actual test itself. As I mentioned, the test can be done all with scratch paper in your head. It's multiplying, dividing by 10, 5, easy stuff, right? But let's calculate this out. Let's see what we would need for this patient here, right? And so what are we going to do? First, let's see if you have the right answer. So you can pause it here if you'd like. Wait to see if you can work out the right answer. And then the answer is 13 mLs. So how does that work out? Well, let's go ahead and bring up, let's say, a Word document here. We'll just start up a new document. And basically we'll see here. Okay, so the patient is 23 kilograms. And our drug is 80 milligrams per ml. And the patient is going to be getting, actually we're just, concentrations there. Just again to keep things straight. Weight is there. And our dose is 90 milligrams per kilogram per day. It's BID. So that means that's going to be 45 milligrams per kilogram per dose, right? Because we're going to be dividing that in half. So how do we figure out how much we're giving? Well, let's go ahead and do 23 kilograms times 45 milligrams per kilogram per dose. And what does that equal out to? Let's use our handy dandy calculator. We'll say 23 times 45 is 1,035. It's milligrams per dose. So, of course, you wouldn't want to tell the mom, hey, go ahead and give 1,035 milligrams per dose. That doesn't really tell you a whole lot. So then we got to figure out how much to give based on the concentration. So we'll take 1,035 milligrams per dose, and then we'll then divide that by 80 milligrams per ml. The milligrams will then cancel out. So 1035 divided by 80, and you get 12.9 mLs. And so that would be per dose, right? So 12.9 mLs per dose, you can just round that to 13 and you're good to go, okay? Again, that's a little bit more complicated just because the numbers didn't work out to nice round answers. So just be aware of that. But on the test, scratch paper is going to be fine. You don't need a calculator for the intensity of the questions that we've written. All right, up next. Which medication can be administered via endotracheal tube to premature newborns with respiratory distress syndrome? It would be Baractin, Lumicaftor, Ivacaftor, dexamethasone, or caffeine. Well, the right answer there is what we're going to use directly in the lungs. And so that's actually going to be our surfactant. Baractin is going to be a surfactant replacement for premature neonates who have respiratory distress syndrome. If you remember, Lumicaftor, Ivacaftor is better for CF patients, right? It helps to increase expression of those CFTR transporters and is useful only for CF, right? Dexamethasone is good to help with stimulating surfactant production, but itself is not given within the lungs. And the caffeine is good for dealing with neonatal apnea. It helps to stimulate the respiratory drive and the brainstem, but is not going to be given in the lungs. Which of the following drugs can be used as a mucolytic in the CF patient? Dorniaz alpha, 3% saline nebulization, tobramycin, or azithromycin. So, two of these are actually correct here. Dorniaz alpha is an enzyme that is going to be able to directly cleave some of the proteins in the mucus and help to make it a little bit more, free-flowing, decrease the viscosity there. The 3% saline nebulization helps to incorporate more water into the mucus to make it less viscous. And so both of those would be considered mucolytics, right? So just making it easier for the patient to clear it when you're doing things like their chest physiotherapy, either the vest or manual percussion, you're going to find that helps to get things moving a little bit more easily. Tobramycin is oftentimes used as an inhaled antibiotic for these patients. Usually after you finish the CPT, you've given the bronchodilators, you've given the mucolytics, they've kind of cleared everything out. Now you want to give your antibiotics via the inhaled route. You can use this, you can use colistin, there's amikacin, lots of different things. And that will get really good lung penetration right there within the lungs themselves, right? So again, typically when you use those antibiotics last, and it's part of their respiratory regimen. The azithromycin is going to be used more for inflammation than it is for antibiotic purposes for these patients, and that's when you'll normally see like Monday, Wednesday, Friday dosing with azithromycin as opposed to say everyday dosing as you would see for a typical infection. And last but not least, which of the following is the most appropriate for a 4-year-old male to prevent constipation? We're going to use a glycerin suppository, sodium phosphate enema, polyethylene glycol, or magnesium hydroxide, which is most appropriate to prevent constipation. The right answer is polyethylene glycol, or Miralax. So looking at these, we're looking to prevent constipation as opposed to active treatment for it. And so, non-absorbable fibers like Metamucil, like your psyllium husk, all that good stuff, is good for prevention of constipation, and a lot of patients will just be put on Miralax, say 1 capful a day, which is 17 grams for prevention of constipation. Now, bigger doses of Miralax, which is an osmotic laxative, can stimulate defecation if they needed to treat constipation. Similarly, magnesium hydroxide is also a good treatment for that. Sodium phosphate is fine from a rectal standpoint if you want to administer that as an enema. Glycerin suppository could be potentially useful, but this is more seen for neonates and infants that will receive glycerin suppository if they are really constipated. But again, not used for prevention, that's used for acute treatment. And the result is I won and lost all in the same time, but really I think it was you guys that really won, because you still got a review at the end of it. So anyway, that's that. I'm going to go ahead and post this up, and then if you have any questions, feel free to let me know. I'm sure I'll be studying hard, and I will be answering my emails through the weekend. And I will see you guys when I see you. Thanks so much.